I think one of the things that I was really struck by with both of these articles is just, especially I think the network of breathing one, was how extensive like the whole system really is, how interwoven the various body systems are with the diaphragm. And so reading it, I was kind of amazed and also a little bit maybe overloaded perhaps with a sense of like, you know, where do you enter into the system? What kind of point of access is most beneficial? Is it the obvious kind of, you know, area of pain or contraction that the client may be presenting, or is there some kind of, you know, secret spot that, you know, through some knowledge of deeper knowledge of this system, you might access the floor of the mouth, the base of the skull, the occiput, down to the pelvic floor, all of this sort of visceral connections, the heart, lungs, you know, stomach, et cetera, and how they're all sort of woven in with this kind of core muscle action. And I found that to be incredibly powerful, and also, yeah, somewhat of maybe an interesting, you know, clinical conundrum. Like how do you even start?
How do we meaningfully focus our therapeutic attention on a structure which is so connected, both anatomically and functionally, with so much else in the body? How do you make use of that hour or 90 minutes that you have precious time to make a meaningful difference for a person in your care? The answer to your question lies in the context of the therapeutic session. So the first thing that is so important for anyone in your care is to listen to their story, listen to their experience, and listen to what for them would be better, right? And so if in their clinical history, their goal setting, they talk about digestive function, or they talk about a history of trouble with birthing, or they talk about a shortness of breath in a specific functional context, or they talk about a somato-emotional dimension to their breath. These are examples of narrative elements in the story of your patient, which can clue you in to potential avenues of connection. So if somebody's got, you know, pelvic floor dysfunction, as well as diaphragmatic dysfunction, it would make a lot of sense to investigate the connections between those. The other answer to your question about how to deal with that complexity is to just try stuff. Yeah. With, you know, really trusting your intuition, but while you try stuff, keep checking in with the response of the body in your care. So, you know, we talk about autonomic tracking skills. This is crucial for any practitioner. What is happening to the breath rate and breath volume of your patient when you're engaged with a specific spot or structure or behavior? What is happening to the warmth in the skin, the dilation of the pupils, the sound of the voice? What is happening to the systemic muscle tone? What is happening to sort of the experience, the sensory experience of the person, the emotional experience? All of these are kind of broad autonomic indicators, which fall to me into like three categories: nope, and aha, right? Hallelujah. And so if I'm doing work on a part of the body and the body says, no, thank you, I don't like that, that's characterized by protective behavior. That tells me maybe this is connected, but it's not the place to be right now, you know? Versus, I don't know, or yes, that helps so much. There's a sense of body coming alive in response to your work. Yeah. And that helps me, that kind of autonomic conversation helps me not get too clever and just follow try stuff and audition things with a listening attitude, such that the body itself can guide me into the most relevant connections.